Hi guys, welcome to my channel. In today's video, we're going to be talking about recurrent aphthous ulceration. So this is a super common condition that practically all dentists will see in patients. It presents with recurrent small, round or ovoid ulcers with circumscribed margins, erythematous halos, and a yellow or grey base. It typically starts in childhood or adolescence and tends to resolve with age. In about 1/3 of patients with recurrent aphthous ulceration, there is a positive family history, and it affects at least 20% of the population, with the highest prevalence in higher socio-economic classes. Recurrent aphthous ulceration can be divided into 3 subtypes based on their clinical characteristics. So we have minor recurrent aphthous ulceration, major, and herpetiform. In the minor category, you'll typically see 2 to 6 ulcers per episode. These ulcers generally will involve non-keratinized mucosa, so this would be the labial mucosa, buccal mucosa, floor of mouth, and ventral side of the tongue, and they typically heal in 10 to 14 days without scarring. Major recurrent aphthous ulceration present with large ulcers, typically 1 to 3 centimeters in diameter. They come about either singly or 2 to 3 at a time. They involve both non-keratinized and keratinized mucosa, so the keratinized mucosa being the hard palate, attached gingiva, dorsal of the tongue. They may last a month or even longer, and they heal by secondary intention, often with scarring. Lastly, herpetiform recurrent aphthous ulceration, which is called this because the clinical appearance can look like that of primary herpetic gingivostomatitis, even though herpes viruses have not been found to be involved with this type of ulceration. So herpetiform recurrent aphthous ulceration presents as small pinpoint ulcers of over 10 at a time. These can coalesce to form larger ulcers. They may involve keratinized mucosa, and they heal without scarring. So what causes recurrent aphthous ulceration? The cause is unknown, but there is likely to be an immunological factor involved. We do know that there are a number of underlying or predisposing factors involved, which we'll talk through now. So trauma is one of them. Stress. It's been found that the frequency and severity of recurrent aphthous ulceration can increase during stressful periods. Food allergies, so food additives like benzoates and flavouring agents. Chemicals such as sodium lauryl sulfate, SLS, which is a detergent in many oral healthcare products like toothpastes. Smoking cessation. It's been found that many smokers who stop smoking can suddenly experience recurrent aphthous ulceration. Hematinic deficiency, so deficiencies of iron, folic acid, vitamin B12, etc. Gastrointestinal disorders, including celiac disease, Crohn's disease, and ulcerative colitis. Immune deficiency, for example, HIV. Vasculitic disease, including Behçet's syndrome and lupus erythematosus. And finally, drugs, including non-steroidal anti-inflammatory drugs, cytotoxic drugs, and nicorandil. So how do we come to a diagnosis? The diagnosis of recurrent aphthous ulceration is made on the clinical appearance of the ulcers and the recurrent nature of them. In some major recurrent aphthous ulcerations, one might need to take a biopsy because solitary lesions can resemble neoplasia. How do we manage recurrent aphthous ulceration? In order to answer this, we need to think about a few things. So number 1, we need to think about identifying and correcting any possible predisposing factors. Number 2, we need to think about identifying possible systemic disease. And thirdly, we need to think about the medical management of recurrent aphthous ulceration. So for example, in terms of predisposing factors, patients with recurrent aphthous ulceration should be advised to avoid foods containing benzoate preservatives, such as potato chips, crisps, or chocolate, since many sufferers implicate these foods in the onset of ulcers. Another example is trauma, Perhaps the patient is wearing an appliance that is causing trauma to the mucosa, or perhaps the patient is going through a stressful time. In terms of systemic disease, in order to rule out haematological deficiency, we need to arrange for the patient to have some investigations. You would especially want to do this if the patient reports symptoms of GI disease, heavy menstruation periods, or a vegetarian diet, for example. Blood investigations should include a full blood count, assessments for vitamin B12, corrected whole blood folate, and ferritin levels. Also investigations for celiac disease. In terms of medical management of recurrent aphthous ulceration, many patients can get relief from mouthwashes, such as chlorhexidine or benzidamine. Some patients may need application of topical steroid preparations, such as hydrocortisone, triamcinolone, fluocinolone, beclomethasone, or betamethasone. Systemic medications can also be used in severe cases in specialist units. These can range from systemic steroids like prednisolone to immunosuppressants like azathioprine. That's everything for this video today. Thanks for watching.